Hi, everybody. My name is Stephanie Aniel. I'm a social worker at Epilepsy Toronto, and I will be talking about functional seizures today. So functional seizures is a condition that is known or goes by many names. In North America, this condition is commonly referred to as psychogenic non-epileptic seizures, or PNES. In the UK, it is a condition known as dissociative seizures, but also known as stress seizures, functional seizures, episodes or attacks, or functional neurological disorders, FND, or otherwise known as FND. I prefer the term functional seizures, and so that's what I refer to them as. That all being said, I will, when I'm working with a client, I will, use whatever terminology they prefer. So how common are functional seizures? Up to 33 per 100,000 people are thought to have functional seizures. And this is a condition that's as common as Parkinson's disease or multiple sclerosis, just to kind of put those numbers in context. About 20 to 40% of patients in epilepsy monitoring units have functional seizures. And somewhere between 5 and 20% of people having seizures are actually having functional seizures. So know the facts. Functional seizures, they tend to begin in adolescence and young adulthood, but certainly not as a rule. Really, I've worked with clients for who these seizures have started at a variety of ages. They're experienced by approximately 12% of patients with epilepsy. So some folks have both a diagnosis of functional seizures and epilepsy. About 3/4 of this patient population is female, and it is a condition that has been found across cultures and continents, so all over the world. So before we actually get into what are functional seizures, I'll start with what is a seizure. So a seizure is a sudden, temporary, and involuntary event that causes changes in behavior, movement, sensations, and/or awareness. Okay. Very broadly speaking, there are 3 types of seizures. So there are epileptic seizures, which are probably the most commonly known. Epileptic seizures reflect a temporary abnormal electrical activity occurring in the brain. There are also physiologic non-epileptic events, also known as PNEE, and these reflect a metabolic or medical issue, but it's not epilepsy. So examples of PNEE might be sleep disorders, cardiac events, fainting, or certain movement disorders. Functional seizures, on the other hand, reflect a temporary problem with the functioning of the nervous system. So you can think of functional seizures as a problem. If a human being is a computer, you can think of a functional seizure as a problem with the software. The functional seizure is like a software malfunction. There's a problem with how the system is functioning. What causes functional seizures? So functional seizures happen for different reasons in different people. So there isn't really a straightforward answer to this, because it's a little bit different for everyone. However, the biopsychosocial model can help you to understand what causes your seizures or your loved one's seizures, and what areas to focus on in treatment. And research has actually shown that patients who are assisted in integrating their personal experiences into their perception of their illness find it easier to accept the diagnosis, understand the diagnosis, accept the diagnosis, and move forward with the diagnosis. So the biopsychosocial model is a way of looking at a condition. It involves looking at biological factors, so physical, medical factors, social factors or environmental factors, the things that happen to us, and then psychological factors, so the emotional and cognitive responses that we have to the biological and social factors. Within this model, we'll look at predisposing, precipitating, and perpetuating factors. So predisposing factors means the stuff that happened way back when. Precipitating factors, what's happened more recently, and how did you respond to it? How did it affect you? And then perpetuating factors. What are the chronic things that are going on right now that might be maintaining the condition or maintaining the seizures? Okay, so that's kind of an overview of this biopsychosocial model and how we can use it. In looking at this model, I've really populated the model with the factors that we know can contribute to the development of functional seizures in a person. Okay, and so it's not to say that every person that has functional seizures experiences every single one of these factors. It's just to say that these are some of the known factors that we know precipitate functional seizures. Okay, so I'm gonna talk about predisposing, then precipitating, and then perpetuating factors. And I'll start with biological, I'll flip over to social, and then talk about psychological factors in each category. So in terms of predisposing factors, so those factors that happened, in childhood, way back. The biological predisposing factors that we know may contribute to the onset of these seizures are actually having a diagnosis of epilepsy, having an intellectual disability, or structural abnormalities in the brain. The social predisposing factors could be adverse childhood experiences. So if you Google adverse childhood experiences, you'll come up with a big list of about 10 to 12 items. But adverse childhood experiences, known adverse childhood experiences, generally speaking, are when a person experiences abuse or neglect in its various forms. Another social predisposing factor is having a family member with epilepsy. And then psychological predisposing factors include certain personality traits, so avoidant or anxious personality traits, maybe factors, as well as having a history of anxiety or depression. Okay, so those are some of the predisposing factors that we know can contribute to the onset of these seizures. In terms of precipitating factors, so the things that maybe happened more recently in a person's life, biological precipitating factors include having a mild TBI or a concussion, some type of injury or medical illness, or experiencing hormonal changes are all biological factors that can precipitate the seizures. In terms of social precipitating factors, a stressful life event or an accumulation of stressful life events can certainly precipitate the onset of these seizures. And then in terms of precipitating psychological factors, learned and reinforced responses to stressors or to stressful life events can certainly contribute to these seizures. And so this looks like certain beliefs that we might develop about ourselves, others, the world, coping behaviors that we adopt to get through difficult times, emotions that we experience. In terms of the perpetuating factors, so the chronic things that are going on right now that help kind of sustain or maintain the seizures, biological perpetuating factors include changes in nervous system functioning. So once a person is having functional seizures, their nervous system is functioning a little bit differently. Other chronic health challenges certainly can be a perpetuating factor. In terms of the social factors that are perpetuating, not being believed, I've spoken with many folks that unfortunately have functional seizures and have had the experience of not being believed or being told that their seizures are fake. The stigma associated with this condition, losing a job or a sense of security, and isolation are all social factors that certainly can be perpetuating factors. And then in terms of the psychological perpetuating factors, worry and fear, the stress, the anger, the frustration, or the shame that can come along with this diagnosis certainly can be perpetuating factors. And so again, I just want to make it clear that not that everyone's map, everyone's biopsychosocial model will look a little bit different. It's not to say that if you have functional seizures that these are all your experiences, only that are there some of these pieces that are relevant to you that might be contributing to the onset of your seizures. And so just to highlight how the biopsychosocial model can help, I've just included a case example here talk about one person's functional seizures. Okay, so Emily is a 20-year-old female. She was diagnosed with functional seizures, and her seizures started when she was 16 years old. Okay, and so for Emily, we determined that her predisposing factors were as follows. So her predisposing biological factors, she had a learning disability. Her predisposing social factors, she experienced emotional abuse and neglect during childhood, and she witnessed physical violence towards her mom. And then her predisposing psychological factors included, she said that she was a shy, nervous child. And she said that when she was a little kid and she was witnessing some of this physical violence or experiencing some of this emotional abuse, she would go to her room and turn off the lights, and she would just stare off and experience a kind of numbing sensation and go blank. Okay. For Emily, we determined that her precipitating factors were as follows. So biological precipitating factors, she did have a history of having a concussion, which is a mild traumatic brain injury. Her social precipitating factors really included that she was finding high school to be quite stressful, as it is for many people, right? But with the learning disability and just some stuff that was going on at school, school was very stressful at the time that her seizures started. And then the psychological precipitating factor included that really the way that she coped with those stresses, that she avoided thinking about her difficulties. That's how she coped. Okay. For Emily, her perpetuating factors were as follows. So biological perpetuating factors was a change in her nervous system functioning. Okay, she was having seizures. She was having functional seizures. The perpetuating social factors included not being believed. She lost job opportunities due to seizures. She felt isolated. Once she was having a seizure in class, and although she couldn't respond, she could hear, and she heard a teacher speaking negatively about her. And her family really didn't understand her condition, which was difficult for her. And the perpetuating psychological factors we determined together was that she avoids thinking about her difficulties. And in fact, she didn't even really know when she was stressed or angry. She really had a hard time articulating and identifying, oh, actually right now I'm stressed. Right now I'm really sad. And so because she couldn't identify that, it was hard for her to be able to do anything about it. Okay, so I hope this example kind of highlights how this model can help a person sort out how the seizures might have developed, and also where you can target treatment. Because in Emily's case, she couldn't do anything about having had a concussion or having had some difficult experiences in childhood. But in our work together, she was able to focus on these psychological pieces, right? To help her manage and treat the seizures. And so that all being said, what are functional seizures? So multiple factors usually lead to the onset of functional seizures. I hope I've established that much. But we know that for many people with these seizures, psychological factors play an important role. These seizures may reflect a reflex-like response to emotional distress that the brain is detecting. The brain automatically uses physical symptoms, in this case, the seizures, as a way to express distress or discomfort. And this is called dissociation. So I'll just say that last part again. So these seizures may reflect a reflex-like response to emotional distress that the brain is detecting, and the brain automatically uses the seizures as a way to express distress or discomfort. Okay. So your brain does this in the same way as how a person might step out of the way of a puddle while walking along a sidewalk and talking to someone without ever becoming aware of the puddle. They just step over it. It's like this, it just kind of happens under the radar, right? So what is dissociation then, right? If this is what's happening when functional seizures occur, what is dissociation? So dissociation describes a feeling of being disconnected from your surroundings or from your own body. Okay, so being disconnected from your surroundings or your own body. It can be quite mild. So when a person is in a daydream, for example, or a bit spaced out, or it can be more severe. So, if a person is able to hear, but they're not able to respond to those around them. It can be a weird feeling that's hard to describe, but it's actually quite common. It's a switching off process in the brain that happens unconsciously without you thinking about it or even being aware of it. And it actually happens to all of us. So, for example, if you're concentrating on getting something done and someone calls out your name and you don't hear them. If our minds weren't able to do this, we would never be able to get on with anything because we would just be constantly bombarded by too many sights and sounds and sensations. For some people, dissociation occurs during really scary events as a way to protect ourselves. Over time, if this becomes habit, it can cause troublesome symptoms, as is the case for people who have functional seizures. So a protective response in childhood may become a habituated response to any emotional distress so that a person's nervous system now functions differently. That's dissociation. So, a question that does come up sometimes when a person is diagnosed with functional seizures, are you telling me that these seizures are all in my head? And the answer to that is absolutely not. These seizure symptoms are very real. Functional seizures embody the integration of our mind and body, right? And the body may be functioning differently, at least in some part, because of what's going on in the mind. And as humans, our inner states are frequently expressed as physical symptoms. If you just think about emotion expression, we might cry when we're sad, we might blush when we feel embarrassed, we might shake with anger. And then we can take that a step further and reflect on times when our emotions that have maybe been tucked away manifest as physical symptoms. So tension headaches or butterflies in the stomach. These are responses that we don't control, they just happen. And then that is because our minds and bodies are integrated. So what does a functional seizure look like? Functional seizures can vary greatly from person to person, and actually in the same person, functional seizures can range as differently as well. They can present differently in the same person. So they can range from intense shaking of the body's limbs and or head to complete paralysis with an inability to speak. So it's really kind of a spectrum of symptoms that occur that might be a little bit different for each person. So I will talk a little bit about typical features. No single feature characterizes functional seizures, but there are some common functional seizures. So an aura, or a warning signal, is a change in perception. It can last from a few seconds to a few minutes. It occurs right before the seizure. And some patients report lightheadedness, nausea, headaches, heart palpitations, visual disturbances, strange tastes, smells, hot flashes, or just strange feelings. And then a person might experience changes to motor movements. So again, that can range from paralysis to intense shaking and jerking movements. A person might experience changes in awareness, consciousness, or memory. So about half of folks with functional seizures report some loss of awareness and impaired memory. Some report feeling distant, and others report going blank. There might be a change in speech and sound production. So again, this can range from an inability to speak to making loud noises. Injuries and loss of bladder control are possible. So a person might fall and sustain an injury due to the fall. They might lose bladder control, and they may bite their tongue. The duration is greatly variable from person to person and from seizure to seizure. And then the person returns to baseline, which just means they return to they're back to their typical selves. I don't have a slide for this, but for those of you that have functional seizures and epileptic seizures and are wondering, how do I tell my seizures apart? This is an important one. And I'd say, first of all, work with your doctor to determine, what are functional seizures and what are epileptic seizures. There are some features that may be indicative of functional seizures, though again, to be clear, one symptom alone does not indicate that a seizure is functional or that a seizure is epileptic. But symptoms that may indicate functional seizures are an especially long duration, prolonged waxing and waning of seizures. So that means like the seizure symptoms come and go and come and go and come and go. Eyes are closed during the seizure, crying during the seizure, and then recall of information after, recall of what occurred during the seizure once the seizure is complete. Okay, so again, this by no means is this a rule, and I really encourage folks to work with their doctor to determine, you know, what seizures are epileptic, and yeah, really work with your doctor to determine which of my seizures are epileptic and which are not. So diagnosis, how are these seizures diagnosed? So functional seizures should be diagnosed by an epileptologist or another doctor familiar with seizures. And there's a few things that an epileptologist will look at. So they will note what others have said about your seizure events, or they'll watch videos of your events. They'll conduct a physical exam. They'll ask about the symptoms and the history of the seizure events. And then do a video EEG or VEEG test. This really is the gold standard for determining whether seizures are functional or not. The doctor is able to watch an episode, a seizure, on video while also seeing your brainwave activity, because you have the EEG, because you're wearing the EEG. So in functional seizures, brainwave activity during an event will be normal. Functional seizure first aid. So if you are a person with functional seizures, or if you have a loved one that has functional seizures, what is first aid? So first of all, stay calm. Keep the person safe from injury. So move any dangerous objects away. If they're wandering, you know, just kind of gently keep them from wandering into danger. Consider moving the person to a low stimulation environment. Don't restrain the person. Don't put anything in their mouth. And know that the episodes will resolve without any intervention. We highly recommend that folks with any type of seizure create a seizure response protocol and share it with the people in their life, so that the people around them know what to do in the event of a seizure. And I will talk more about a seizure response protocol down the line. So when should 911 be called? So call 911 if the person got hurt during the seizure. If the seizure looks very different than what is typical for the person. If the seizure is a lot longer than what is typical for the person, or is longer than what is typical for the person. If the seizure occurs underwater, if the person's pregnant, or if the person has uncontrolled diabetes. So these are the circumstances in which 911 should be called. Okay, so let's move on to recovery. So for some people, the diagnosis of functional seizures itself leads to a resolution of functional seizures. For others, a specific treatment, usually psychotherapy, is necessary. And yet others can learn to live full, healthy, meaningful lives alongside seizures. You know, having seizures does not preclude a person or exclude a person from being well. Where do you start, right? Where do you start on the road to recovery? So I'm going to talk a little bit about learning more about functional seizures, creating a seizure response protocol, tracking and monitoring your seizures, and considering treatment options. So this is really where you want to start when you've received a diagnosis of functional seizures. So these will be posted. All of these resources will be posted alongside the video that's posted on the epilepsy education website. But you can also Google these. The first two are websites, and PNES, Psychogenic Non-Epileptic Seizures, and the FND Guide have a lot of really great information. A book, Psychogenic Non-Epileptic Seizures, a guide by Lorna Myers. It's great. It's available. It's available online. There's a free documentary online called Dissociated. I believe it's produced in the UK. And then the International League Against Epilepsy has posted some research, peer-reviewed research on its website as well. And so again, learning about it, and this goes for any condition, right? Learning about your condition is an important first step in figuring out how to manage it. So second, create a seizure response plan. So this is a part of our seizure response plan template that we work on with clients at Epilepsy Toronto. And again, this can be really important for identifying and helping a person with this seizure type to disclose their seizures to their loved ones. And the front page really is the seizure information, what happens when I have a seizure. And then the second page, which you can't see here, but the second page is all about seizure response. What do you want people to do when you do have a seizure, when you do have a functional seizure?
And if I'm not mistaken, Stephanie, this seizure response plan is also available on Epilepsy Ontario, like the actual document. Is that correct?
If it is, I didn't know that it was available.
Yeah, I think
it's
I
very
think that
possible.
it is.
Yeah,
I think that
but
it is.
we've also this plan, this seizure response plan is a little bit different for functional seizures. We've adapted it a little bit.
Oh, okay.
Seizures. So if there is a spot, if you are indeed correct, which I'm sure you are, then this will make its way to Epilepsy Ontario's website as well.
Yeah, I think I think I saw it on the website.
Yeah, so if that's the case, then I'll have to get this particular seizure response plan on the website, and then maybe I'll add it to the list of resources that you have, so that you can post.
Yeah,
it.
if you can send me that document so I can add it. Yeah, so you know what, Stephanie, the resources booklet that I had asked you for, if you can include that in it, just so that you know, persons who are interested in, you know, having a copy of this can have access to it.
For sure.
That'll be great.
Yeah, no problem.
I just wanted to add something, sorry, just before you go on. So I was previously I was trying to show the resources page on our the resources on our web page. And so it appears that one of the links, types of seizures, that one isn't working with all of the other links. I checked it, they are working. So I just have to rectify that one link. But you should be able to access all of the other links for reading resources.
Okay.
I just wanted to add that.
Okay. Thanks, Carol.
No problem.
Okay, so what else can you do on the beginning of your road to recovery for functional seizures? So tracking your seizures is really important. It can help you or your loved one determine the seizure triggers. So what are the situations that might trigger or lead to a higher likelihood of seizures? It can help you identify your warning signs. So figure out, you know, do I have an aura? What does that aura look like and feel like? And in these ways, you can keep yourself or your loved ones safe. Tracking, you know, really tracking your seizures and the triggers and so on can be done in whatever way works for you. Some people like to use an app. Some people just want to use pen and paper, and that's fine. We have a spreadsheet that, you know, that I'll send folks sometimes. But really it's not so much how you're tracking it. It's the information that you're tracking. So you want to track the day of the week, the time of day, the duration of the seizure, the severity of the seizure, describe the symptoms that you experienced and that, you know, if anyone was around you, what they saw, the location of the seizure, any triggers, meaning what happened right before the seizure. You know, were you thinking about something? What were you doing? And then what was going on that day? You know, were you feeling really tired that day? Did you maybe get in an argument with someone that you were feeling a bit upset about? You know, what was going on that day? And so tracking your seizures can really help you. And also in conversations with your doctor and your healthcare providers can help sort out a way forward as well. And then considering treatment options. So studies have shown that functional seizures can be treated effectively through a number of psychotherapies. So I'll briefly talk about each one of these. So cognitive behavioral therapy is a type of therapy where individuals learn and apply skills to change thoughts and behaviors that maintain the seizures, therefore reducing the frequency of seizures. Mindfulness-based psychotherapy is also a type of therapy where individuals learn and apply skills to relate differently to their internal experiences. As awareness is improved, that's thought to improve control of behaviors and symptoms, including functional seizures. Interpersonal and psychodynamic psychotherapy aims to help folks identify the underlying emotional conflicts thought to lead to functional seizures. And by expressing these conflicts in a more effective way, functional seizures are less likely to occur. Prolonged exposure therapy is a specific type of cognitive behavioral therapy, or CBT, for individuals that experience functional seizures and PTSD. This type of therapy helps individuals emotionally process past traumatic experiences by confronting distressing memories and situations in a safe context. And then family therapy is not intended to be a private or a primary therapy, but it's an adjunct or an add-on to any of the above therapies. Certainly when the person that's having seizures is a teenager or a child. Okay. So those are the treatment options to consider. And then in terms of Epilepsy Toronto services, so the services immediately available for people with functional seizures is education and counseling to help understand maybe some of the circumstances which may have led to the seizures, to help you understand the diagnosis if you are struggling to understand it. And we can refer you to community therapists in private practice that specialize in functional seizures, if you have insurance coverage or if you're able to pay for therapy. In 2022, for folks that have a diagnosis of functional seizures, we will be starting to offer a CBT-informed psychotherapy and a peer support group for the folks that access the therapy. And then down the line, we'll be offering a psychotherapeutic group, although I'm not sure when that will happen. So thank you for listening. This is my contact if you do have any, if you'd like to reach out, if you'd like to be added to our wait list for services, or if you just have any questions about functional seizures, I can certainly try to answer them. You can also find Epilepsy Toronto on TikTok or on Instagram, and that's our website right there.
Thank you so much, Stephanie. Great presentation. That's a topic, your topic is normally a very popular one with our patients at the clinic. So it's definitely great to have you present today. So what I'm going to do, I have a few questions in the chat here that I'm going to start with. The first one is, how can a person tell the difference between an epileptic seizure and one of these functional seizures, which I think you kind of briefly explained already.
Yeah. And, I would really encourage you to work with your doctor, hopefully an epileptologist, to help you differentiate between the two. Because although there are some common features that I did mention, it can be complex, but epileptologists are trained to be able to identify seizure types.
There's another one. Do these PNES cause shaking, like stiffening, dizziness?
They can, yeah. Yes, they can. Okay. So intense shaking is definitely a symptom of functional seizures for some people.
Okay, I have another one here. This is pretty, I don't know if you want to just, okay, let me read it through. Okay. So when dealing with seizures in a child, it is difficult to get information from them to assess if it's a functional versus genuine seizure. Outside of a neurologist, are there any other assessments that can be recommended to understand it, to understand if psychotherapy is a good option? What type of specialist would you recommend? The concern is that after a certain period of time passes, emergency medicine would be administered inappropriately, are there government-funded treatment options for some of these therapies that were mentioned? Example, CBT, mindfulness, interpersonal, or psychodynamic that are mentioned.
Okay, so I guess I'll start by saying that I only work with adults. So I'm not necessarily familiar with, the services that are available for children. And so let me just see. So when dealing with seizures, it can be difficult to get information from them. Yeah, so I mean, I think that in terms of the diagnostic process, seeing a neurologist, and I would recommend seeing an epileptologist, and then asking the epileptologist if they have a psychiatrist or psychologist that they work with within that clinic that your child can maybe be referred to. A psychiatric assessment is not a bad idea, I think, for this population. I mean, I think you can do, in terms of monitoring the seizures, you can only do what you can do, right? And so write down what you see, and bring that information to the specialist that you're working with. And yeah, I think, are there any government funded treatment options? I'm not familiar. Again, I work with an adult population, so I'm not familiar with treatment options for children. And so I can't answer that question, unfortunately. I can try and find the information though, and get it to Carol, or you can reach out to me, and I can connect you with my colleagues in Child and Youth Services at Epilepsy Toronto, and see if they can help you with that. But yeah, I work with adults, so I hesitate to to provide any much more than that in terms of advice for working with children that have functional seizures.
Yeah, I don't know if in some cases if your child is connected with sick kids, maybe there's a social worker there that might be able to provide some information about supports or funding for a child.
Yeah, because Sick Kids has an epilepsy monitoring unit, right, as well.
Yeah.
So I mean, getting connected with an epileptologist at Sick Kids is probably your best bet in terms of diagnosis and sorting out a way forward.
Yeah, I would say that. And if you're not connected already with a neurologist or epileptologist, maybe speak with your family doctor to make a referral. If this is something that you're concerned about, I would say. Someone is typing, so I'm just going to wait to see if they're. Okay, no, they were just saying thank you. Okay. Any other questions? We have a few more minutes. And I've already put the feedback form in the chat if you want to complete that while you're waiting. Feel free to do that. Your feedback is definitely appreciated. We always like to get feedback to know if there's anything that we can improve on or anything that you would like us to do, more of next time. Because this is, for patients, so we want to ensure that the information that you're receiving is beneficial. So if there are no more questions, there's one. As a clinician, if we suspect PNES, would you recommend we ask questions regarding past trauma or focus on the medical piece and refer to a psych specialist to go more in depth?
I would suggest that if you suspect PNES, that you refer to a neurologist and further an epilepsy specialist, or sorry, an epileptologist, because they specialize in seizures, as a first step.
And so I think she was asking if you would recommend it that you ask about if the practitioner, if they should ask about past trauma or just focus on a medical issue.
As a
So they're
nurse practitioner.
Yeah, if you should,
I mean, I think it depends on the setting that you're working in. If that's part of your role, you know, I think that you know, if you have background training in mental health and those pieces, but I think that the best that you can do to support the patient is to get them on the road to someone that can diagnose them either way.
Okay. Okay. So I think anyone else, any other questions? We have 5 more minutes. Questions, comments, suggestions?
Questioned out, maybe.
Okay, so I would say that we can probably close off here, and if you can fill out the feedback forms, that would be great. And thank you, Stephanie. This was very useful information. I always learn. I always learn a lot when I attend or facilitate these workshops. So it's a learning, it's a sharing and a learning experience for me.
Yeah, absolutely.
Someone is typing something there. Okay, let's see. I think you're not quite off the hook as yet, Stephanie. Oh, they're just saying thank you.
Just a thank you.
You love
Not just thank you. I appreciate the thank you. Yeah, it's a condition that I think is gaining more attention and support as time goes on. And so my hope is that there's more help for folks out there 5 years from now than there is right now, for sure. So, and more information. Yeah.
That's great.
Yeah.
Okay. Thank you everyone for attending, and enjoy the rest of your day.
Bye everybody. Thanks for coming.